Huh?
So, hello students, how are you? I hope you are doing very well, studying continuously.
How are you?
So, today we are here with another session of integrated learning. And today I am with Dr. Sarath Balaji, who is a pediatrician. And the agenda for today's topic is that we are going to discuss, we will integrate both pediatric seizures and the drugs or anti-epileptic drugs which we will be using in for the treatment of pediatric seizures. So first, the sir will tell you about all the seizures disorder, febrile seizures, status epilepticus, how to diagnose it, what are the conditions, what are the hallmarks you need to remember. After we are finished with pediatrics, we will jump over to the pharmacology part. We will discuss the treatment of these seizures, and we will also discuss the classification of all anti-epileptic drugs. तो सबसे पहले हम स्टार्ट करेंगे pediatric से. So over to Sarath Balaji, sir.
Hi, Ankit. Hi, my dear students. Now, as Ankit told, we have integrated our discussion into two. One is the first part, I am going to discuss about the pediatric seizure disorders, and the treatment part will be dealt by my friend Ankit. So to start with, let me go to the session directly. In this half an hour of pediatric session, we are going to discuss about what do you mean by a seizure disorder, what are all the terms that you need to know. Second, as you all know, there will be one question definitely on a febrile seizure, whether it is a typical or atypical seizure, and the treatment part and what are all the new things that we need to know will be dealt by Ankit. And what do you mean by status epilepticus and what are all the new definitions with respect to status epilepticus we are going to see. Next one. So to start with, first of all, before jumping into the topic per se, you need to know what do you mean by seizure. You all know that heart is nothing but a flow of current. In the same way, your brain is also nothing but a flow of electrical current. When there is an abnormal short circuit, it will manifest in the form of seizures. So what do you mean by seizure? Seizure is nothing but a transient. So it comes and goes. Occurrence of signs. What do you mean by signs? The child may be throwing seizures, abnormal aura. So many things can happen. Because of which thing that occurs, it occurs as a result of excessive as well as synchronous exaggerated neuronal activity in the brain. That is called as a seizure. And these seizures can be of two types. It can be acute symptomatic seizures. What do you mean by acute symptomatic seizures? Whenever you have hypoglycemia, hypocalcemia, meningitis, or a trauma, any acute event can irritate your brain, as a result of which you can throw up seizures. This is called acute symptomatic seizures. Majority of them will respond to corrective measures taken for the etiology. For example, treat hypoglycemia, treat hypocalcemia, relieve subdural hematoma, give antibiotics. In this way, you can give seizure management for acute symptomatic seizures. What do you mean by remote symptomatic seizures? You might have an injury, or you might have had a stroke. So, or you might have an hypoxic ischemic encephalopathy in the newborn period. So what happened? During that previous episode of brain damage, there would be some structural damage that would have happened to the brain. As a result of structural damage, that particular area of part of brain will be abnormal and throwing seizures. This is called remote symptomatic seizures. Here, you can't treat the etiology. You need to give anti-seizure medications. This is called seizures. Then what do you mean by epilepsy? Okay, epilepsy means when you have 2 or more unprovoked seizures, lasting for more than 2 or more unprovoked seizures, if it comes after a span of 24 hours, it is called as an epilepsy. And then you need to know what is an epileptic syndrome and what is an epileptic encephalopathy. Epileptic syndrome means it occurs at specific age of onset. Some seizures occur in the infantile period. Some seizures occur in the newborn period. Some seizures can occur in the childhood period. So it has got specific age of onset, and the seizure type will be specific for each and every syndromes. For example, in West syndrome, you will have infantile spasms. In Lennox-Gastaut syndrome, you will have a generalized tonic-clonic convulsions, like that. Then, what is called epileptic encephalopathy? Encephalopathy means usually whenever epilepsy comes, you give anti-seizure medication, the child becomes normal till the next seizure comes, if it comes. But in case of epileptic encephalopathy, as the seizure progresses, whether it comes and goes, each and every episode of seizure or epilepsy will impair a type of damage to the brain, as a result of which it will end up in neuroregression. What will happen? So over a period of 6 months or 7 months, if the child is throwing seizures, previously developed or acquired milestones will be lost. That is called epileptic encephalopathy. Loss of previously acquired milestones as a result of seizure is called as epileptic encephalopathy. So this is our first concept. So you need to know the basic definitions first. Then we need to know what are all the type of seizures. Next one. Right. So that seizures, the type of seizures can be classified as follows. If the child develops sustained contraction, it is called tonic seizures. If the child is an alternative contraction, so if it is rhythmic, then it is called clonic seizure. Sustained contraction is called tonic seizure. If that sustained contraction comes and goes, it is called clonic seizure. Then what is called myoclonic seizures? Remember, this tonic seizure is usually due to some damage to the brain. For example, in a newborn, we usually think in terms of a intraventricular hemorrhage. Clonic seizures, usually due to hypocalcemia. Among this tonic seizure and clonic seizures, what we need to worry about this myoclonic seizures. So what is this myoclonic seizures? Myoclonic seizures are nothing but shock-like rhythmic contraction. This is a shock-like state which lasts for less than 50 milliseconds. This is called myoclonic seizures. Remember, my dear friends, among all these seizure types, the one which has got very bad prognosis is myoclonic seizures, and often in pediatric age group, it is associated with inborn errors of metabolism. Then, what is called astatic or atonic seizure? See, I am speaking in front of you in a camera. Suddenly, if I drop my head momentarily and then again gaining my tone, this is called astatic or atonic seizure. Momentarily loss of tone with sudden fall. Okay, your body tone suddenly falls and you will gain it back. This momentarily loss of tone, which is short lasting, is called as either astatic or atonic seizures. And finally, what is called infantile spasms? Infantile spasm means your flexion and extension of truncal or extremity musculature, and it lasts for less than 1 to 2 seconds. For videos regarding this tonic seizure, clonic seizure, infantile spasm, astatic or atonic, you can find all those relevant videos in our app. Then, you all know that infantile spasms are usually associated with the West syndrome. And finally, you keep on speaking and then you shut your speech momentarily for about a second. Or you blink often, which lasts for 5 to 10 seconds. This is called this staring, your eye fluttering, lasting for a few seconds is called absence seizures. Absence seizures are usually provoked by hyperventilation. Mother or father may say something like this, staring, suddenly she is staring, suddenly she is blinking. And when you are examining, you might not witness that episode during that time. But when you ask the child to hyperventilate, it will be obviously manifested not only in EEG, but also clinically. I repeat, among the all seizure, the one which is going to produce a problem is myoclonic seizures. Okay, now we all know that previously we have simple febrile seizure, complex febrile seizure, so many things. But by 2017, the European guidelines for epilepsy management had classified your seizure based on two things. So what are all the two things it was based on? One is whether it arises from one cerebral hemisphere or both cerebral hemisphere. If it is arising from one cerebral hemisphere, it is called focal onset seizure. If it arises from both the cerebral hemisphere, it is called generalized. I repeat, focal onset means one cerebral hemisphere. Generalized means both cerebral hemisphere. And with respect to focal onset, we will classify as follows. Focal onset means what? It arises from one part of one cerebral hemisphere. In that, we will divide into two. Whether consciousness is maintained or consciousness is not maintained. If consciousness is maintained, it is called focal aware seizures. I repeat, if consciousness is maintained during seizure, if the child is able to maintain, able to interrogate, able to have eye contact with you, it is called focal aware seizures. Previously, it is called as simple partial seizures. I repeat, my dear friends, right now, we do not use the term simple partial and complex partial seizure. We use the term focal seizure with awareness, previously called as simple partial seizure. Whereas, if this seizure is associated with loss of consciousness or altered sensorium, it is called as focal seizure with impaired consciousness. I repeat, it is called focal seizure with impaired consciousness. Previously, it is called as complex partial seizure. It is called as complex partial seizure. Now, in this focal onset, that is, the child is maintaining consciousness, then it will be divided into two. If the child is maintaining conscious, means it is called focal seizures with awareness. It is divided into two. Whether motor involvement is present or motor involvement not present. Motor involvement present means what? The child can show some form of motor movement such as tonic, clonic, myoclonic, so many things that we had discussed right now. So motor means it can be obviously seen. As I described already, clonic, tonic, myoclonic, astatic, in those ways it will present with. Whereas non-motor means usually behavioral disorders. As we discussed, absence seizure, sudden fluttering of eyes, suddenly stopping listening to you, all those things are non-motor things. So your focal awareness will be divided into two things. One is motor, another is non-motor. Sometimes the child will manifest in the form of emotional liability. So seizure can manifest as increased angriness, so many things like that. And then when you come to focal seizure with impaired awareness, again this is divided into motor and non-motor. As we discussed already, motor means what? It involves some form of motor movement, whereas non-motor means it can be either emotional or sensory or autonomic, either in the form of increased heart rate, increased sweating. In those instances, it can present with. So we had discussed about focal onset. Focal onset means single cerebral hemisphere, which is divided into with consciousness, without consciousness. With consciousness is otherwise called as focal aware seizures. Without consciousness is called as focal impaired awareness. Both divided into motor, non-motor. Next one, please. Okay, now you have generalized onset. Now you have generalized onset. In generalized onset means what? It usually involves two cerebral hemisphere. The spike arises from two cerebral hemisphere, and here again it is divided into, as we discussed already, motor, non-motor. Motor means with visible physical movement, whereas non-motor means either in the form of autonomic disturbances or sensory. That is what we had discussed in previous slide also. If you don't know from where it is arising, whether it is single cerebral hemisphere or double cerebral hemisphere, if you are not aware of it, then it will be called as seizure of unknown onset. And here again, it will be divided into motor or non-motor. Okay, and then unclassified. If your seizure doesn't fit into any of these categories, it will be called as unclassified. Because if you can't visualize the seizure, majority of the time, it will be difficult to fit into particular diagnosis that can be classified under unclassified seizures. Next one. Right. Whenever you suspect a seizure, the first and foremost thing is as a pediatrician, we will ask the father or mother or granny to take a video of that particular episode. Only when you take a video of the core seizure episode, you can find out whether there is a motor or a non-motor, whether it is awareness or without awareness. All those clinical symptoms and signs can be revealed by taking a simple video of the time when the seizure occurs. So apart from pattern recognition, this is called pattern recognition. So the first one is video recording of the seizure episode to identify the pattern. After knowing the pattern, this is called subjective assessment. See, each and every time you have one is subjective assessment, second is objective assessment. Subjective assessment is mainly based on symptoms and signs. What the patient says, symptom. What you witness is called sign. This is called subjective assessment. As a undergraduate, you need to know the subjective assessment. With symptom, I need to get a diagnosis. With sign, I need to get a diagnosis. With symptom and sign, form a pattern recognition. With this pattern recognition, right now you need to confirm the diagnosis. How will you confirm the diagnosis? Diagnosis can be confirmed by taking an electroencephalogram. EEG will be taken. So, there are certain specific markers, I can say, specific type of EEG which will conclude what type of seizure you are dealing with. Sometimes, as we said already, video recording cannot be taken. Sometimes even when you witness, it will be so difficult for you to have a pattern recognition. Anyway, you need to have one pattern recognition based on symptom and signs. Then you need to confirm your diagnosis by taking an EEG to identify what specific pattern of seizure disorder, what specific pattern of abnormal electrical activity is taking part in the brain. These are all the certain EEG pattern. When you have a spike pattern followed by slow waves, it is typical of an interictal EEG. So normally you will have a smooth wavy pattern. So you are sitting in a beach a series of waves are coming to you. So it is called as what? Slow waves. But at times, suddenly one height wave with a tsunami-like wave comes near you. What is that called? That is called a spike. So this kind of tsunami wave and normal wave is otherwise called as spike and slow wave pattern, typical of an interictal EEG. Second, as you all know from your younger undergraduation, when you have a typical 3 spike and a wave pattern, 3 spike and a wave pattern, it is typical of an absent seizure. That means what? You see 3 tsunami waves and then one normal wave. 3 tsunami waves and then one normal wave. This is called absent seizures. Okay. Now, what is called hypsarrhythmias? As you all know, my dear friends, even in our previous discussion, we have discussed one type of seizure. What is that seizure called as? Salam seizures or epileptic spasms. What happens? Your truncal musculature will go for sudden flexion and extension. This is called as what? Hypsarrhythmias. So in those cases, what kind of wave pattern you will see? Chaotic high voltage and multifocal spikes. What does it mean? When you think you are seeing a tsunami-like wave, you will see a normal wave. When you think that a normal wave is going to come, you will get a tsunami-like spike. This confused pattern of multifocal tsunami waves and normal waves occurs in hypsarrhythmias. I mean, tsunami means the altitude of voltage. The amplitude of voltage, I am relating it to tsunami waves. What is called myoclonic waves? Myoclonic means what? Brief burst of polyspikes. So what does it mean? Brief burst of polyspikes. Slow normal waves are coming. Suddenly 2 or 3 tsunami waves. Again slow waves are coming. Suddenly high amplitude waves. This is called, but this is very, very, very short lasting. This is called myoclonic seizures. And finally, what is called Rolandic seizures? Here, particularly, you will have spike wave in centrotemporal areas. See, you are sitting in the beach. When you see tsunami-like wave in one particular seashore, it is called Rolandic seizure. So what will be the manifestation of this centrotemporal area spikes? Suddenly, by about early morning, the child will wake up. The child will wake up. You all know that temporal lobe is associated with auditory function. So what will happen here? The child usually wakes up, will look at you, have a confused picture, and because of the involvement of parietal motor areas and frontal areas, what will happen? The child predominantly in Rolandic seizures will have seizure movement, particularly involving the facial muscles, as if the child is angry looking at you. So the child will have bizarre facial movements and drooling of saliva will be there, particularly in the early morning. This is called Rolandic seizures. And finally, when you have a specific pattern of generalized tsunami waves here and there, a group of tsunami waves then become normal, a group of tsunami waves then become normal throughout the seashores. This is called generalized periodic epileptiform discharges, and it occurs in subacute sclerosing panencephalitis. In which condition you will get this subacute sclerosing panencephalitis? Any child with neuroregression. What do you mean by neuroregression, my dear? You are seeing a 8-year-old boy. Previously, he could see. Previously, he could speak. Previously, he could walk. Now, he lost the ability to see. He lost the ability to hear and continuously throwing seizures, not able to walk. This is whenever you see this kind of neuroregression, loss of previously acquired milestones, you need to think about neuroregression. One cause for neuroregression is subacute sclerosing panencephalitis. So it is mainly due to the presence of measles in the brain. So what investigation you need to do? You need to do anti-CSF measles antibody. You need to do anti-CSF measles antibody. 1 second. Okay, anti-seizures, measles, antibody onset. Right. Then, what is called lateralized periodic epileptiform discharges? The investigation of choice is anti-CSF, measles, antibody. Then, what is called lateralized periodic epileptiform discharges? When you see this group of tsunami waves in one particular area of brain, in one part of the seashore, it means that particular area is having some abnormal activity. What is that abnormal activity? This kind of periodic epileptiform discharges, if it particularly occurs over the temporal lobe, it is called temporal lobe encephalitis. My dear friends, when you see abnormal MRI pattern in bilateral temporal lobes, it is highly suggestive of herpes simplex encephalitis. Whenever temporal lobe is involved, there will be an abnormal behavioral pattern. That's why in herpetic encephalitis, a child will show little bit of seizure, but compared to seizure, there will be more of behavioral abnormalities. So fever low grade, seizure, behavior abnormalities, all in favor of HSV encephalitis. When you suspect this, take an MRI, look for the involvement of temporal lobe, and take an EEG, look for lateralized periodic epileptiform discharges over the temporal lobe. You all know the treatment of choice is acyclovir for 21 days. Next slide. Right. There are plenty, dozens and thousands of syndromes associated with seizure. But as far as an undergraduate is concerned, you need to know only 4 types of syndrome. There are plenty. But as far as this discussion is concerned, let us concentrate only on 4 types of epileptic encephalopathies, which is often asked in our entrance examination. First syndrome, West syndrome. What is called West syndrome? West syndrome is characterized by epileptic spasm. As we discussed already, what is called epileptic spasm? Sudden flexion and extension of the truncal musculature lasting for a few seconds is called as West syndrome. And you all know that if it comes for about 6 months to 1 year, the child will lose all its acquired milestones, and this is called neuroregression. And finally, EEG, it was already discussed. What is that? Suddenly tsunami waves, suddenly normal waves, suddenly tsunami waves, suddenly normal waves. What we call it as hypsarrhythmias, chaotic multifocal spikes are suggestive of West syndrome. So what is called Lennox-Gastaut syndrome? Lennox-Gastaut syndrome is also an epileptic encephalopathy. What do you mean by epileptic encephalopathy? After occurrence of series of seizures, the child will lose its acquired milestones. So again, this is also associated with the neuroregression. But compared to West syndrome, in Lennox-Gastaut syndrome, it is not a fixed pattern. The child sometimes shows tonic seizure, sometimes clonic, sometimes myoclonic. So each and every time the seizure pattern varies. That's why multiple type of seizure pattern. When you have multiple type of seizure pattern, obviously you will have multiple types of EEG pattern. This is called Lennox-Gastaut syndrome. And finally, very important and the most commonly asked question is called Dravet syndrome. As a pediatrician, I can say Dravet syndrome is otherwise called as pertussis encephalopathy. What is that? Yes. See, you have 2 types of PACs in whole cell pertussis and acellular pertussis. This whole cell pertussis is prone to produce encephalopathy. Whenever any child worsens after a dose of pertussis vaccine and the child is encephalopathic with the altered sensorium after receiving this vaccine, we will call it as vaccine-induced encephalopathy. If this vaccine-induced encephalopathy leads to continuous seizure on and off, it is otherwise called as Dravet syndrome. Remember, in Dravet syndrome, initially the child will develop seizures following vaccination. But over a period of time, the child will develop seizure even without vaccination also, along with the continuous neuroregression. I repeat, Dravet syndrome is, unless otherwise proved, it should be called as pertussis encephalopathy. And then the last one, Landau-Kleffner syndrome. What is called Landau-Kleffner syndrome? Sir, 1 year back, I saw him. He is my classmate studying in 9th standard. Okay, I changed my school to 10th standard in some other school. Last time when I saw him, he used to converse. He is such a good boy with a good scholastic performance. When I meet him right now, he could not speak, sir. He is dumb, sir. He is not at all speaking. Anything happened to his vision? No. Anything happened to his auditory function? No. Anything happened to his brain? No. So despite being a normal ear, normal eye, normal Broca's, normal temporal lobe, the child will lose its ability to speak. The child will develop aphasia. Despite normal vision, audition, temporal, Broca's area, if continuous seizure occurring in those areas will automatically leads to acquired aphasia. This is called as Landau-Kleffner syndrome. Any child after a period of continuous seizure, if they lose their ability to speak, this is called acquired aphasia. So often it is mistaken for autism. In autism, comprehension will not be there. In Landau-Kleffner, comprehension will be there. Second, why seizure is not that evident? Remember, my dear friends, seizure often silent and seizure occurs during sleep. That's why EEG during sleep should be taken in Landau-Kleffner syndrome. I repeat, EEG should be taken at sleep in Landau-Kleffner syndrome. So these are all the 4 important syndromes that you need to know with respect to seizure disorder. Next one, Ankit. Okay, last but not least, what do you mean by a febrile seizure? Between 6 months to 6 years. There are numerous definitions. Some countries like 3 months to 6 months, some 6 months to 6 years. For an undergraduate, a febrile seizure means any child who develops seizure following fever between 6 months to 6 years is called as febrile seizure. That itself can be divided into 2. One is typical. Typical means, sir, each and every time when my child develops fever, it will land up in seizure. How many episodes, ma? The episodes are only one per day. How long it lasted? Less than 15 minutes, sir. Do you need to go to the hospital? No, sir. It resolves on its own. After seizure, before seizure, my child is pakka, sir. Is there any weakness involving one part? No, sir. This is called typical febrile seizure. What is called atypical? Each and every time, even for a particular day, seizure, multiple episodes of seizure, not one episode, multiple episodes of seizures. Even that single episode will last for more than 15 days. Either before seizure or after seizure, the child will be neurologically abnormal. And there will be some focal signs, whether it is motor or sensory. That is called atypical seizures. Okay. The treatment part we will discuss together. Okay. This is called typical seizure. That is called atypical seizure. Majority of them will resolve after 6 years. If after 6 years, this fever-provoked seizures are otherwise called as febrile seizure plus, the same children usually resolves by about 6 years. If after 6 years they develop seizure with fever episode, that is called febrile seizure plus. Okay. Next, prophylaxis. By a simple point, treatment will be discussed by us. When will you give this? The mother is so much bothered. Sir, do I need to give prophylaxis, sir? Each and every time seizure coming, sir. Is there any possibility to stop, sir? Do I need to give you a medication, sir? Sometimes when we go to some park or some other areas while playing, if fever comes, it can land up in seizure, sir. Whether I need to give you a drug, sir? Yes, drugs can be tried. I repeat, drugs can be tried, not should be tried. Drugs can be tried if within 6 months, 3 or more episodes, within 1 year, 4 or more episodes. And if the child is young enough, first episode, less than 18 months, family history of febrile seizure, majority of them will say, sir, my father had, my mother had, I had, sir, that's why my child is having. I repeat, family history of febrile seizure, not seizure disorder, family history of febrile seizure. And even at the first episode itself leading to multiple seizures, you need to think. Some will say, sir, only at 40 degrees Celsius, my son is developing seizure. But some will say, sir, even for 39, he is getting seizure. When seizure occurring at low temperature, when there are multiple seizure at the first episodes, you need to consider intermittent prophylaxis. Not all abnormal movements, my dear friends, not all abnormal movements should be considered as seizures. Psychogenic seizures. You all know adolescent girls are prone, I'm extremely sorry, more common in adolescent girl. How to know? How do you know that the child is throwing simply? He knows that he or she knows that voluntary movements are made by him. It is not due to abnormal electrical activity of neurons, abnormal electrical activity of mind leading to psychogenic seizure. How to identify this? When they avoid eye contact with you, it is psychogenic seizures. Avoid eye contact with you. When they have more of pelvic thrust, it is called psychogenic seizures. And you all know about prolactin levels, normal prolactin levels during seizure episode. That is what will be discussed in medicine part. What is called 𝐶𝐻? Sometimes there will be a borderline low BP. When these patients suddenly stand up, they will fall like anything. And this hypoxia can lead to seizures sometimes. Remember, syncopal attacks will always occur in standing position. That's the clue. Will always occur in supine to sitting or sitting to standing. Treatment is lie down. Head down position. That's it, treatment. No need for any anticonvulsant. And finally, what is called breath holding spell? You just look at me. What is called breath holding spell? The child is asking something. You are not giving. The child starts crying. Just 5 seconds I am doing. If it goes and goes on and on like a Duracell battery, almost this crying is an act of expiration. Almost all the oxygen in the air in the lung will come out because crying is an act of expiration. When all the oxygen in the lung comes out, the brain will go for hypoxia. That hypoxia will go for tonic posturing. This is called breath holding spell. Tonic posturing preceded by an event of excessive crying. And finally, what is called benign sleep myoclonus. You would have witnessed to your siblings, you would have witnessed to your father, mother, or granny. Suddenly, one particular muscle will act for a momentum of seconds and then it will disappear. This is called sleep myoclonus. These are all not seizure disorders. Next. Rule out these seizure mimics. I will call it as seizure mimics. Next one. Okay, finally, the last point which I want to discuss is what is called status epilepticus. The previous definition is any seizure lasting for more than 30 minutes is called status epilepticus, or multiple seizure without regaining consciousness in between is called as seizure status epilepticus. This is old definition. But what is the modern definition? Any child who is convulsing for more than 5 minutes, because 90% of seizure will resolve within 5 minutes. Any seizure lasting for more than 5 minutes can be called as status epilepticus. And remember, any child who brought to emergency room throwing convulsion is said to have status epilepticus. These two are all new definitions. What is called refractory status epilepticus? Usually, we give either lorazepam or midazolam or diazepam. Okay, followed by an anticonvulsant. What are all those anticonvulsant? You can give phenytoin, phenobarbital, levetiracetam, any anticonvulsant. When one benzodiazepine and one anticonvulsant is not working, it is said to be refractory status epilepticus. Okay, in those instances, okay, finally we will anesthetize the child. Despite 24 hours of anesthesia, if the child is still throwing seizures, it is called super refractory seizures. I repeat, despite 24 hours of anesthesia, if the child is still throwing seizure, it is called super refractory seizures. Again, to start with, we are not going to deal in depth. Usually airway, breathing, circulation, all those things should be taken care. One. Second point is, you need to stabilize the child. What do you mean by stabilize the child? Correct sugar, correct calcium, airway, breathing, circulation should be taken care. You need to take only 0 to 5 minutes for stabilization phase, followed by 5 to 30 minutes, followed by you need to give an benzodiazepine. Either it can be lorazepam or diazepam or midazolam. Either it can be rectal or oral or IV or IM. Recently, intranasal midazolam had come. Even in some countries, intranasal lorazepam also come. So you can have, when you are in a poor resource setup, you can use either IV diazepam, but compared to that, rectal diazepam is very safer. Still, when you are in level 2 care, you can try IM lorazepam, not IM, IV lorazepam. And finally, the new thing is, right now, don't worry, don't get IM, no rectal. You just take a midazolam spray and put it over both nearest. This is the latest treatment protocol in pediatrics is concerned. When this benzodiazepine, any one of the benzodiazepine is not working, then either phenytoin, phenobarbital, levetiracetam or valproate can be given. I repeat, one of the anticonvulsant, phenytoin, phenobarbital, levetiracetam or valproate. So first 5 minutes stabilize, 5 to 30 minutes benzodiazepine, 30 minutes to 60 minutes anticonvulsant. After 60 minutes refractory, consider midazolam IV infusion. Anesthetize the child with thiobarbital or pentobarbital coma. So anesthetize, knock out the child, ventilate and knock out the child. Beyond this, if it lasts for more than 24 hours, kindly consider vagal stimulation, ketogenic diet. Sometimes they will do surgery to remove the abnormal part of the brain which is showing abnormal electrical activity. So vagal maneuvers, ketogenic diet, surgical removal of that abnormal part of the brain. Next one. Okay, from my side, I will leave it to my friend Ankit regarding the management part. Thank you, Ankit.
Thank you, sir, for teaching such an comprehensive. When I was listening, I felt that you're teaching your experience more rather than facts. So it was such a nice session. So now let's jump over to the pharma part. So in pharma part, how we will approach, we will see the treatment of all these seizures, which drug you will prefer to use. And after that, in the last section, we will discuss the classification of anti-epileptic drugs. Fine. So let's start with these childhood seizures. The first one, which sir has already told, that the most important one is Dravet syndrome, Lennox-Gastaut, febrile and Rett syndrome. So first, let's talk about Dravet syndrome, which is sometimes also known as severe myoclonic epilepsy of infancy. Now remember, the drug of choice for Dravet syndrome is always valproate. But yes, you can also give topiramate and lamotrigine. Depending upon the tolerability, the side effect, we can choose any of the following drug, but valproate is the most effective one. If it is still not responding to valproate, then we add clonazepam. And if it is still not responding to clonazepam, then there is an indication of a new drug. That new drug is stiripentol. So this flowchart diagram must remember for your entrance exam for Dravet syndrome. The next one, which we discussed, was Lennox-Gastaut syndrome in a child 6 months to 6 years of age with acute onset of fever. Sir has very nicely explained. So if we can see, the treatment is very much similar to Dravet syndrome. Again, the drug of choice, we start with valproate, the most effective one. Alternative to valproate are topiramate and lamotrigine. Not control, we add clonazepam. But the last one is different from Dravet syndrome. If it is still not responding to clonazepam, we can add rufinamide and felbamate. Rufinamide and felbamate are the drugs which were specifically developed for Dravet syndrome. So this question which comes very commonly in your entrance exams as well. Then we come to the controversial one, that is febrile seizure. Now, one thing is sure. If there is febrile seizure, the drug of choice is benzodiazepine. Now, which benzodiazepine to be used? Diazepam, midazolam. Which benzodiazepine we will use? That sir will tell. But for the pharma part, remember in our books, rectal diazepam is a very commonly written everywhere, and most of the time we mark that answer only. But what we read in books and how we practice in real scenario are totally different conditions. So I'll ask Dr. Sarath Balaji to tell me what actually happens in clinical practice. If a patient of febrile seizure comes, you classify them into typical and atypical, what drugs you will choose and how to manage that patient? Over to you, sir.
Previously, a decade back, for typical febrile seizures, people used to give intermittent clonazepam. Intermittent means what? As soon as the fever increases, you start giving paracetamol again along with the clonazepam for about 3 days. People said it reduces the seizure episode. This is called intermittent prophylaxis. Whereas for atypical febrile seizures, multiple episodes in a single day, neurologically abnormal after episode lasting for more than 15 minutes. In all those cases, continuous prophylaxis. Either they had used phenobarbital or they had used valproate. But right now, they wanted to balance whether the side effect of the drugs and the benefit of the drugs, which one scores. Either you give intermittent prophylaxis for typical febrile fits or continuous prophylaxis for atypical febrile fits. In long term, it is not going to reduce the seizure episode. As a result of which, the current proven guidelines is no need for any intermittent prophylaxis. When the seizure comes, whether it is typical or atypical, you can use nasal midazolam at home. Parents should be taught about how to use a nasal midazolam spray. This is the current guidelines that is being followed in pediatrics. And with respect to acute event, when the child is throwing seizures, so at home, midazolam nasal spray is the drug of choice. When the child comes, based on the availability, intranasal midazolam as well as rectal diazepam have got equal efficacy. As a result of which, anything can be used, no issues. Both have got the safe efficacy. That's it.
Okay, sir. So I think I am teaching right that rectal or nasal diazepam, nasal midazolam, they are still considered to be the drug of choice. There is a lot of confusion in books what was given earlier, but now as sir has clearly explained, the current guideline says nasal midazolam spray or rectal diazepam, both for typical febrile and atypical febrile seizures. So now another syndrome, that is Rett syndrome. Although previously there was no drug approved for Rett syndrome, but recently there is a disease modifying agent which has a neuroprotective effect in Rett syndrome, which has been approved. Is the drug name is trofenatide. And this question was asked in recent this year INICET exam also. So what is trofenatide? The only drug which has been approved for Rett syndrome, it is IGF-1. IGF is basically insulin-like growth factor. So if you take the initial 3 amino acids of insulin-like growth factor, remember this is trofenatide. So simply trofenatide is a first tripeptide of IGF-1. And it has been shown that it has a neuroprotective effect in brain. And that is why this drug has been approved for Rett syndrome. So this is all about the treatment. We are left with the treatment of one syndrome, that is West syndrome, which we will get back to it. But right now we will start with basically the classification of anti-epileptic drug. As Sir has already explained that what is epilepsy or seizure. In seizure, there is discharge from a neuron. And a neuron becomes discharged simply because when it becomes depolarized. तो जब एक न्यूरॉन depolarize होता है, fire करता है, इस abnormal firing is known as epilepsy. Continuous, if it occurs continuously paroxysmal, we call it as epilepsy. Now the basic question arises, why and how a neuron becomes depolarized? Remember, inside a neuron, we have negative charge. Outside the neuron, we have a positive charge when the neuron is not firing. Now, can we say a neuron will fire when there is a movement of sodium charge inside the neuron? Yes. So if sodium goes inside, it can lead to seizure. So the first class of anti-epileptic drug we have is the drug that block use-dependent sodium channel. So if we block the entry of sodium, the drug will be anti-epileptic drug. So a way to remember the mnemonic, how to remember the drug which block sodium channel is, we can remember with the mnemonic PCB-tall. P for phenytoin, C for carbamazepine, V for valproate, topiramate, lamotrigine, and L for lacosamide. And we have congeners of lacosamide like rufinamide and zonisamide. Now the point to be noted is that first two drugs, phenytoin and carbamazepine, they are exclusive for sodium channel. They don't have any other action, but all these other drugs, they have other additional action also, which we will going to discuss. So they have some additional action also. So the second type of anti-epileptic drug is the drug that block T type of calcium channel. So if we inhibit the entry of calcium, again, the neuron will not depolarize, the neuron will not fire. So the drug that block T type of calcium channel, we can remember with the mnemonic VEL. VEL stands for valproate, E for ethosuximide, and L for lamotrigine. Agar aapko yaad ho, if you remember that valproate also blocks sodium, lamotrigine also blocks sodium as well as calcium. But what about ethosuximide? Ethosuximide is an exclusive drug which only blocks calcium channel. And remember, the drug that block T type of calcium channels, they are given in the treatment of absence seizures. And Sir very well explained you what is the EEG of absence seizure, 3-wave Hertz spike pattern. So remember, these three drugs are the first line drug for absence seizure because they block calcium channel. So if I'll ask you a question, what do you think whether phenytoin and carbamazepine, are they effective in absence seizures? What do you think? So the question is, we know that phenytoin and carbamazepine, they only act on sodium channel. They don't act on calcium channel. So what do you think? Will be they effective in absence seizure? The answer is no. So phenytoin and carbamazepine, they have no effect in absence seizures. They are only given for GTCS and focal seizures. Then what additional things we can do is, we can promote the entry of a negatively charged ion. So if negatively charged ion goes inside, the cell becomes hyperpolarized. Do you agree? So neuron become hyperpolarized, it will become more negative. Negative people don't do any work, hence the neuron will also not do any work. So the point is how we can promote this action of chloride channel. Remember, there is a channel known as GABA-A chloride channel. GABA is a neurotransmitter which acts on GABA-A chloride channel and increase the movement of chloride inside the neuron. How it happens? Let's understand with the help of a beautiful diagram. Suppose there is a neuron which is releasing GABA. GABA is produced from glutamate. And when this GABA is released, it acts on GABA-A chloride channel, which leads to entry of chloride ion inside the neuron. And neuron becomes hyperpolarized. The first class of a drug which will have GABA word in them is pregabalin and gabapentin. Remember, pregabalin and gabapentin, GABA word is coming. They increase the release of GABA. Agreed? The next class of drug we are having is barbiturate like phenobarbital, benzodiazepines, which we discussed, lorazepam, diazepam, etc. These drugs, they directly open this channel. That is GABA-A chloride channel. They are agonist. Agonist means they directly open this channel. Then we have a drug VegaVen. Remember, when this GABA is released, this GABA becomes degraded. It becomes degraded with the help of an enzyme known as GABA transaminase enzyme. So if we inhibit this enzyme GABA transaminase, can we increase the level of GABA? The answer is yes. VegaVen inhibit GABA transaminase. It inhibits the degradation of GABA. Hence, the GABA level will increase, which will open this chloride channel. And the last drug which acts on GABA is, remember, when this GABA is released, this GABA can be removed back with the help of a mechanism known as reuptake. Is GABA ka reuptake ho jata hai with the help of some transporter, let's say GABA transporter. So the drug which inhibits the transporter of GABA is tiagabine. How we can remember tiagabine? T for transporter, I for inhibitor, and you can see GABA word is coming in it. So it inhibits GABA transporter. So sir, how I can remember VegaVen? Let's see how we can remember VegaVen. VegaVen, you can see GABA, TR and IN word is coming. So GABA means it is a GABA, TR means it is a transaminase, and IN means inhibitor. So sir, what word is left? Remember, VI word is left. VI means its side effect, its adverse effect. Remember, VegaVen damages retina, which can lead to visual field contraction. So if you can remember the name VegaVen, everything, the name will tell you. VI for visual field contraction, GABA means it acts on GABA, TR means transaminase, and IN means inhibitor. Now, where VegaVen is used, it is given for infantile spasm, which sir has told as a West syndrome. West syndrome with some genetic conditions like tuberous sclerosis. Now, what is the treatment of infantile spasm? Let's solve that controversy also. Remember, if this infantile spasm is an isolated attack, it is not associated with any developmental or genetic abnormality. In that isolated attack of infantile spasm, during an acute attack, we can give ACTH hormone. The reason is very simple. ACTH inhibits or reduces the level of corticotrophin releasing hormone by negative feedback. CRH is epileptogenic. CRH से ही ये infantile spasm होता है. By giving ACTH, we can reduce the level of CRH hormone. But remember, if this infantile spasm occurs along with tuberous sclerosis, which is an autosomal dominant genetic condition associated with various renal cancers, some sebaceous gland abnormality on face. Remember, if it is with genetic condition, these infantile spasm, they keep on occurring again and again. And it may be lifelong because it is associated with development abnormality. In this case, we have to give anti-epileptic drug, you can say lifelong to a patient, especially children. And the drug of choice or the most preferred drug which we start is VegaVen. But right now we have two new options. One is cannabinoids. They have anti-epileptic action. They can be given. And a neurosteroid, a new drug known as ganoxolone, which can also be given as an add-on drug to VegaVen. Okay, but remember, infantile spasm with tuberous sclerosis, VegaVen, isolated ACTH hormone. Now, When an epileptic neuron fires, it releases glutamate. And remember, glutamate causes seizures by acting on other neuron. So there is a class of a drug which can inhibit the release of glutamate. The name of the drug is levetiracetam and brivaracetam. Cetam word is coming. So these drugs, they inhibit the release of glutamate. Now you know that any neurotransmitter like glutamate, it must be released from synaptic vesicles. All neurotransmitters are inside the vesicles, and when vesicle fuse, they get released. So levetiracetam and brivaracetam, they inhibit this SV-A2. SV-A2 is some synaptic vesicular protein inhibitor. Hence, they inhibit the release of glutamate. Now, the point is, this is the only anti-epileptic drug we have which can increase memory in a person. Increase in memory means nootropic effect. And again, this is the only anti-epileptic drug we have which has antioxidant action, which can protect neuronal degeneration. That is why these drugs nowadays are highly preferred drugs. They are used in variety of epilepsies and they are very good drugs. Now, these drugs, they are also preferred in cases of Alzheimer's disease because of their neuroprotective and memory enhancing effect. Lastly, when this glutamate is released, glutamate acts on NMDA receptor and AMPA receptors. So last class of drug, what we can do is, can we block the receptors of glutamate? The answer is yes. So the drug which is an NMDA blocker, just the brother of glutamate, felbamate and topiramate, you can see mate word will come, just like glutamate. And lastly, AMPA blocker. In AMPA blocker, you can see pirampanel and tilempanel word is coming. So these are the new drugs which have recently got approved. Felbamate has been approved, just we discussed, in Lennox-Gastaut syndrome. And these two drugs, they have been approved for focal seizures. Agree? So this is all the classification of anti-epileptic drug. In pharma, you need to know and integrate which drug to be used in which clinical case of epilepsy in a childhood. So this is all from my side. So back to you, sir.
Okay, and as you said, levetiracetam is a wonderful drug, not only for memory, but also the drug with the least side effects.
Yes.
So it is increasingly being used in pediatrics nowadays to control for long-term as well as short-term purpose.
And so one thing is there that it does not have any drug interactions. All anti-epileptic drug, they interact with CYP enzyme, increase and reduce the level of other drug. And their safety margin is less. But levetiracetam, from pharma point of view, it doesn't have any drug interaction. Yes, sir.
That's it from my side.
Okay, bachcho. So keep learning like this. And tomorrow we will be coming with another integrated session of neurology. So this whole week we are discussing all the topics of neurology in an integrated manner so that we will try to finish each and every topic. It will help you to solve questions in an integrated way. Some questions of pediatric plus pharma you can solve simultaneously. So tomorrow we will be coming with another new topic in an integrated series of neurology. Till then, keep. Anything, sir? Last word? Any last message to our student?
Told everything. So thank you, Ankit. Thank you, my dear friends. So keep tracking us. So we will be teaching you both paraclinical, clinical, and so that it will be a combined effect to make you a good clinician as well as to crack your entrance examination. Thank you. Thank you all once again. Bye from both of you. Both of us. Okay, Ankit.
Thank you, sir.